Okay, so this section is prelude to our 12-lead ECG discussion. Initially, we'll revisit action potentials and we'll set up the 12-lead ECG. We need to understand the flow of electricity through the heart and then the planes that the 12-lead will read in order to generate the trace. And the next set of slides after this, so next week, we'll be interpreting the 12-lead ECGs. And 2 1.5-hour classes is not nearly enough to interpret a 12-lead ECG. There are entire courses over one semester dedicated to interpreting 12-lead ECGs. So we'll hit the highlights. I like that look. I feel that way sometimes looking at them. We'll hit the highlights. There's a lot of detail. You can pull a lot of information from the 12-lead ECG trace. But that's coming up. So, at the risk of beating a dead horse, I thought I would throw in some spirometry review slides because it's always good to review. We've talked at length about COPD and we know what bronchitis and emphysema are. Ultimately, gas exchange is compromised. Hypoxia and hypercapnia are evident in COPD patients. We talked about diagnosing COPD or other respiratory diseases using the FVC test, the forced vital capacity test. It's not only a test of capacity, the forced aspect indicates that there's some testing of function, or there should be testing of function. So complete expulsion of air from the lungs, from full lungs to empty lungs, or as empty as we can go, as fast as we can go, is the forced vital capacity test. And I took you through a few examples of what the traces might look like in different scenarios. Obstruction is probably more common. FVC itself is not generally affected. The capacity is not generally affected by obstructive disease, although it can be, and we talked about a few examples where that might be the case, but with restrictive disease, certainly capacity is reduced. Necrosis, transplant, removal of dead tissue, obviously there's a restriction on capacity. Other indicators, though, are affected by obstructive disease, not the capacity itself, but how air moves through that capacity. FEV1 is often reduced in obstructive disease and more so with more advanced obstruction. There's opposition to airflow. So of course the air will move slower and less will come out in 1 second. Restrictive disease is not often affected or do not often affect FEV1 because the airways that are present are still intact. It's simply that the capacity is reduced. And then we talked about some other factors that help to describe the progression, describe the advancement, or perhaps where the obstruction might take place. The shape of the graph can tell us a bit about these things as well. Okay, not beating that to death. You all got this down, right? And if not, you'll see it on the video. Yeah, Leanne.
Just to clarify, so when in COPD, are both the inspiratory reserve volume and expiratory reserve volumes decreased?
They can be. It depends on the advancement of COPD. A pure obstruction would mean neither is decreased. The capacity should not be reduced.
Would one ever increase?
They wouldn't ever increase. You wouldn't have a larger capacity than normal. But if the obstruction is advanced, I would say if the obstruction is large, if the restriction of the airways is large, that would reduce the capacity of the lungs. Or if there's another component to the disease that causes the volume to be reduced. So perhaps the reduction in surface area and the segmentation of the alveoli, there's many little pockets with a lot of volume, but if the walls are eroded, then there's one larger pocket with perhaps not as much volume. Does that make sense? So I was reluctant to go back and forth on this. I introduced the idea that inspiratory and expiratory reserve can be decreased, but it's not always decreased in the obstructive disease.
Right, but you would never be able to have a larger expiratory reserve volume if
No.
you have COPD?
No. Yeah, good point. They shouldn't ever increase.
And then you're...
That's a physical limitation of the lungs.
Okay.
Okay? Okay. Fantastic. So now we're turning our attention to electrocardiograms and the electrical conductivity of the heart. So we'll review some A&P information on ion channels and membrane potential, propagation of action potentials. We'll review the myocardial conduction pathways at the end of this section on Thursday. But largely we're focusing on depolarization today. And then we'll use that information to set up our basic lead II ECG. Knowing lead II ECG, that's one of the leads in a 12-lead ECG, we can build up a much more comprehensive picture of the electrical activity of the heart, and I'll introduce the information that we can get from that 12-lead ECG. Not just QRS complex, P wave, T wave, and intervals. We can get information on the axis of the heart and the rotation within the chest cavity, whether any areas of the heart are enlarged. Hypertrophy is generally a warning sign for chronic heart disease. If there's been necrosis or infarction, and where in the heart that is, we can get all of that from the 12-lead ECG. So a much more comprehensive picture than simply lead to the classic ECG trace that you all know really well. So let's start with a bit of a historical perspective. This idea of electricity is not a new idea. It was pioneered by Luigi Galvani in 1790 that when he made frogs' legs dance by applying 2 electrodes to them. They moved up and down because we're artificially stimulating or causing a contraction in the muscle tissue. And this was the Renaissance era of science. He was a physician, physicist, biologist, and philosopher. That was his training. That studied how electricity made dead animal limbs move in his spare time. Right? So he was the rock star, or the example of a rock star scientist back in the Renaissance era. Not like nowadays where we study sweat production, collect urine samples, stick people in hot rooms, things like that. So his initial foray stopped with animal limbs, thankfully. Probably had a really weird apartment. And was picked up later, almost 100 years later, by Kolliker and Mueller that started looking at other organs, more complex organs, like the heart. And you can see where the progression is going, from a simple muscle to a more complex organ and organ system. This begs the question, can you ever reanimate an entire body or a corpse? And that's where it's in the newspaper afterwards, January 1803, describing the event. So the event was a convicted criminal that had been executed, George Foster, so don't feel too bad for him. And the attempt to reanimate is summarized nicely in this cartoon, where the devils on the left are using what's called a galvanized corpse, taking on Galvani's name as the father of animal electricity, to entrance humans and lure them down to the underworld. And that's how this was seen at the time. Pretty fantastical, supernatural event. And you can see the description of the whole process, horribly contorted. One eye was open, the right hand was raised as the entire body was set into motion. This is not what we're studying in lab, thankfully. But it highlights the idea that the body responds to electricity. And unfortunately, we can't reanimate dead corpses. We now know there's a lot less mysticism to this process. It's not magic. It's not necromancy. It's all based on the simple distribution of ions and the resulting charge. So taking a very basic science approach. We're leaving the rock star status for now and looking at the simplified version of a cell. Here it's a cardiac muscle cell in sort of that orangey yellow. We can see the difference in ion distribution. Sodium at the left, potassium on the right, and their corresponding concentration gradients. More sodium outside, more potassium inside, and generally those ions don't move voluntarily in and out of the cell. Generally. There is some movement, and we'll talk about that at length today. The differences in the number of individual atoms is meant to represent the sodium-potassium ATPase that always works to pump sodium out and potassium back in, moving 3 sodium out, 2 sodium in. Both have a charge of +1, so the net movement is 1 positive charge out, leaving a negative relative charge inside. And this culminates in a relative membrane potential of somewhere near -90, -100 or more millivolts. That just means the charge differential from the outside to the inside reflects a less of a charge, a negative charge compared to the outside of the cell. And so it's the rapid changing of that potential that results in the electrical impulse and causes muscles to contract and frog legs to jump and hearts to beat and corpses to seize and seem to reanimate. So in our discussion today, it's going to be a pretty complex discussion, but it won't be long. So take that for what you will. Some silver lining. In our discussion today, we're going to focus on a few main ion channels and how they underpin the idea of a resting membrane potential and then the ability of an action potential to form or that resting potential to change. Those are the potassium channels, which we'll lump into one group that usually allow passive movement out, sometimes at rest, other times when more movement is necessary. There are many subtypes of channels, and I'll try to draw your attention to them as we talk about the cycle in detail, but in general, they open to allow passive movement out, which is good if you want to make the potential more negative. Potassium moving out means more positive charged atoms are leaving the cell. Positive out means the potential is decreasing. There are many subtypes of sodium channels, but I want to focus on the fast subtype. You know these as the ones that open to allow fast influx of sodium. They're voltage-gated channels. They also have complementary effects on potassium and other channels. And we'll talk about those when we need to in turn. And they are inactivated after they open up in what's called a refractory period that prevents too many action potentials from being generated. Fast sodium channels open quickly in response to a voltage and allow very quick influx of sodium. It's good if you want the potential to rise, to have a more positive potential. More positive ions in means higher membrane potential, more positive membrane potential. And one that we don't often, or at least I didn't often get to hear about in my undergrad, are slow calcium channels. Maybe you've heard more about them in A&P, or I did you a better service than my prof did. The slow calcium channels are those that are really responsible for the contraction of the muscle. And when I think of these channels and the contraction of muscle, all of this discussion is related to cardiac muscle. The same can generally be applied for muscle, skeletal muscle, or other muscle. But the slow calcium channels are those that allow the sustained contraction, the squeezing of cardiac muscles, that prolong the action potential. And it's one of the main factors that differentiate cardiac muscles from skeletal muscles. Skeletal muscles are more forceful and acute. Cardiac muscles have a longer contraction duration because of these slow calcium channels. And there are other channels that we'll introduce. There are 8 to 10 of them listed on the one main diagram that we're going to discuss. But these are the general types that I think you should know. And so in general terms, if I were to draw a cartoon of membrane potential as it changed while a signal was being sent, this is the action potential. It might look something like this. And this is very similar to what you've already seen. We start with a very low membrane potential, near negative 90 or negative 100 millivolts, that rapidly increases when a signal is present. That signal could be sodium coming in through gap junctions, or it could be the electrical propagation of signals along the plasma membrane. But for some reason, potential goes up and it triggers those fast sodium channels to open, sodium to rush in, and membrane potential to rise. Once we get to our upper limit, we reach a plateauing in cardiac muscle where the slow calcium channels are open that allow the squeezing and activation of cardiac muscle, contraction of cardiac muscle over a longer period of time. These are generally only responsive at a higher membrane potential, something that's not so negative, and we don't have any potassium escaping the cell to change that potential and inactivate the calcium channels. This ensures slow, sustained contraction of the cell. And next, in very general terms, a third phase where we have the restoration of balance, repolarization. Potassium channels open. A quick efflux of potassium means there's less positive inside, which brings the membrane potential back down. Calcium channels close, so calcium can't come in and mess up the potential as we try to re-equilibrate. And then we have the constitutive action of the sodium-potassium ATPase, pumping sodium out, potassium in, with that inequality in charge for every series of transports. And in rough terms, I've overlaid the descriptive periods. The depolarization really should stretch a bit more to the left, but once we are depolarized, there is a period of depolarization where the membrane potential is positive or less negative. After activation of those sodium channels, we have that refractory period where they can't be activated again, which is good because we wouldn't want to initiate this signal if we weren't back to a repolarized equilibrium state. And then the contraction is highlighted in orange at the bottom during the plateau where the muscle actually contracts to squeeze cardiac muscle. So a lot of overlapping phases, but the refractory period ensures that nothing can be initiated again until it's done. It's the longest phase to make sure that no second potentials are activated. So this is a stylized cartoon diagram. We'd like something a bit more like this that gives us more detail. And this is where our discussion will focus for the rest of lecture. We're going to learn this in depth. But when we're done, we'll call class early for the day. So this should look fairly similar. The trace is almost identical to what we just saw, and if you understood what we just saw, this won't be a problem. Same general shape. The red line is the trace of the millivolt potential of the interior of the cardiac cell. You can see it goes up, there's a general plateau, goes back down. We want to understand how and why that happens. So we have the millivolt potential during an action potential, during a signal for contraction. And APD at the bottom simply means action potential duration. That's the span of the green line at the bottom. And also importantly, all the individual boxes are meant to indicate the action of different channels. A downward arrow means influx. They're also color-coded in yellow. ions moving into the cell. Upwards arrow means an outflux. Ions moving out of the cell, and color-coded in gray. So to help differentiate the different kinds of channels, we have the basic color coding in the arrows. And the subscripts give us a lot more detail than we care about. There are potassium channels and sodium channels. There are primary or secondary channels. Some of them are activated in response to acetylcholine. Some of them are voltage gated. We don't care about that level of detail, but we do care about the gross overarching type. Potassium versus sodium versus calcium. And I'll highlight where there are fast and slow channels when we get there. Also, before we get into this, I want you to note our discussion is on the solid red line, which is characteristic of most cardiac muscle cells, but that dashed red line at the end is what would happen if we were looking at a pacemaker cell, like the sinoatrial node, or the IV node, or even the Purkinje fibers. There's a much more rapid automatic depolarization that occurs. But our discussion right now focuses on the solid red line, which is a normal cardiac muscle cell in the rank and file responding to upstream signals, not necessarily depolarizing on its own. What else should you know before we start? All the I's simply refer to ion channels. The subscripts are the types. The NCX at the bottom right is a sodium-calcium exchanger. That will come into play later. It's not so important now. It moves 3 sodiums out for 1 calcium in, kind of like the sodium-potassium ATPase. But it helps to restore calcium balance. Actually, while we're on that topic, it also contributes to the pacemaker function, the dashed line that you see there. So let's progress through this in a nice orderly manner, starting with our resting baseline scenario. Phase 4, as it's called. The resting situation where we have an established membrane potential that's generally not moving, or if it is changing, it changes really slowly. And it is always changing, but it changes very slowly in typical cardiac muscle cells. The reason that it can change really slowly is that these cells are permeable to potassium leak. That is, some potassium can always leave the cell. Potassium always does want to leave the cell. We know that there is a gradient for a high concentration of potassium in, low concentration out, but it's generally opposed by the charge gradient. There's some movement out, but it's not rapid, it's not quick. The positive charge outside tends to resist that movement. Importantly, the angle of the increasing potential, how quickly this will depolarize spontaneously, is affected by blood potassium. And so any changes in blood potassium concentration can really mess up what we call the automaticity, the likelihood for spontaneous depolarization of cardiac muscle cells. So we want potassium to leak out. We don't want it to leak out too quickly because we don't want these typical cells to depolarize on their own. We want them to respond to signals, and those individual pacemaker cells have signals that depolarize themselves rather quickly. We'll see that at the end. So phase 4, some ion leak, generally stable membrane potential. Whenever there's a signal present to depolarize the cell, sodium channels open very quickly in phase 0, which is also referred to as the upstroke, to cause rapid influx of sodium, a rapid increase in the membrane potential that eventually spikes at positive levels. So the charge inside the cell is greater than the charge outside the cell, which is not the norm. And this signal is received by a typical cardiac muscle cell. Usually, through sodium movement through gap junctions, there are actual holes between adjacent cells, and ions can move between them. The charge can move between those cells too. And as sodium moves into a normal polarized cardiac cell, it raises the membrane potential to a point where depolarization occurs. That's the upstroke, and that's highlighted by that tall, skinny, faded column there. Rapid influx of sodium. Also notice the yellow ion channel on the left-hand side with the downwards arrow pointing inwards. That's responsible for the rapid movement of sodium in. Pretty straightforward, nothing new and unusual here so far. So we're in a situation where we have lots of sodium inside and lots of sodium outside and a positive membrane potential. This can be dangerous. If we get too much sodium inside, we lose the gradient. And so we need to protect the sodium gradient. We never reach a point where they are in balance. Even though there's massive influx and a lot more sodium in the cell than there normally is, it's still relatively a lower concentration than outside. But it's rapidly approaching equilibrium. We call that the equilibrium potential, or the equilibrium constant, the point where the two sides of a membrane are in balance. So we don't want that to occur. And the way that we protect the cell from reaching that balance point is we have a latching mechanism. A latching mechanism that is based on the very quick pulsing, the opening and closing of potassium channels. And I'm referring specifically to the very topmost one, the I with the subscript TO. That's a potassium channel, indicating potassium is flowing out of the cell when that's open. And the TO means transient outward. That's just for interest's sake. It's a very fast, transient outward channel. So potassium moves out very quickly, but it's only active for a very short period of time. And you can also see on the bottom the dashed black lines indicate when each channel is open. ITO is the third one, very small duration, very quick pulse. And that pulse is important because it protects the internal membrane charge. When we open this channel, potassium has been chomping at the bit to leave because it's no longer opposed by the positive charge outside. It's got this high concentration in, and it wants to leave the cell. As soon as that channel opens, it can. And it does that quickly. Less positive inside means the membrane potential drops. That's that very quick, steep latching mechanism. We see a quick rebound as those ion channels snap closed again. Helps us to avoid sodium equilibrium, which would probably invalidate this entire cycle. I'm not exactly sure what happens, but we never reach it, and I think it's bad to reach it, so we'll leave it at that. So this notch allows very quick outflow of potassium that is quickly shut off once we've captured the membrane potential and it stops increasing. Now we're in a situation where the sodium and potassium concentrations are messed up, but the charge is positive. And in this positively charged state, calcium channels can open, allowing calcium from outside the cell to move into the cell. And we want these to stay open, so we need the membrane potential to not change very much. We need it to stay somewhat positive here, and this allows the calcium channels to stay open. We don't want it to hyperpolarize, we don't want it to depolarize, so the complementary, there are slower potassium channels that open. Basically, calcium in is matched by potassium out. Charge stays pretty stable. The ion flow is balanced. And it's balanced to allow continued movement of calcium, which directly activates the sarcoplasmic reticulum to initiate contraction. It binds to something called a ryanodine receptor, but we don't need to know about that. It's a latch that opens the sarcoplasmic reticulum, allows calcium to activate contraction in the same way that you were taught in A&P. And we won't talk about the initiation here, just the signal. So we have this generally slow, sustained plateau and contraction period in a cardiac myocyte, which is good. Squeezing of cardiac muscle cells. While ion flow is balanced, it's not perfect, and there is some decrease in the potential. Some of that has to do with the sodium calcium exchanger. Too much calcium in is not a good thing. There's a reason that it's stored in the sarcoplasmic reticulum. It's a very potent signal. And so to remain sensitive to that signal, we start to put calcium away if it's in the cell for too long. And that putting calcium away is a major part of final repolarization, along with restoring sodium balance and restoring potassium balance. We close potassium channels so there's no more influx from outside the cell. We activate the sodium-calcium exchanger, so we're pumping calcium out and moving sodium in. We activate SERCA, the sarcoplasmic reticulum calcium pump that moves calcium out of the cytoplasm into the SR, trying to sequester it. Eventually returning the positive charge back down towards a more negative polarized membrane potential. Here we have the constitutive action of the sodium-potassium ATPase as well. Sodium out, potassium in to restore the ion balance that we indicated right at the start. And the action of all of those transporters is what brings the membrane potential back down to normal or resting. Here shown as negative 80 millivolts. We've seen it as negative 100, negative 90, but a very negative polarized membrane potential. So there's a lot of individual discussion of ion channels that might be somewhat complicated and overlap. But did that overall make sense? 4 phases. Who wants to take a stab at describing phase 4? Let's just go back through them. Anyone want a chance to describe phase 4? What happens in phase 4? Yeah.
Phase 4 is like when it's at rest, so then the potassium wants to leak out.
Okay.
To go against the concentration, or to go with the concentration gradient.
Good. Okay. So at rest, there's some potassium leak. It can leave the cell. It wants to because the concentration gradient drives it. It doesn't want to because the charge gradient opposes it. But there is still some small leak. Good. What's next? Upstroke. Phase 0. Stuff happens. What is that stuff? Sodium gates open. Okay, so tell me more about that.
Sodium enters into the cell,
Okay.
decreasing the resting potential and making it more positive.
Increasing the resting potential, making it more positive.
Yeah.
Yes, direction is important here, but that's very good. Yeah, sodium rushes in response to some signal. We now have an influx of positive ions that raises the membrane potential very quickly, as shown here. And the signal for sodium to come in is what normally? Might be a couple.
Usually voltage gated.
Voltage gated channels, yeah, those open up, and something else that might help. What's the second one? How else does sodium get into a cardiac muscle cell?
Sodium from another cardiac cell.
Yes, exactly. You guys both had it. Gap junctions, sodium from another cardiac cell that's attached to it. Sodium moves through the gap junctions into that cell. Both of those act to increase sodium inside the cell. The very quick, rapid increase, more due to the voltage-gated channels, but some of it is gap junctions as well. Okay, what about phase two, the plateau? How do we ensure that we latch that membrane potential first? Who wants to explain that portion of the plateau? How do we get to a stable potential?
Is that like the quick opening and closing of that transient outflow of the potassium?
Yes, it is. Absolutely. So, quick opening and closing. Let's explore that idea. What would it do to quickly open and close a potassium channel?
What would it take? Is that around?
What does that do? Describe how it results in a stable membrane potential. That's the goal. We want to reach a plateau. How does quickly opening and closing the potassium channel make that happen?
Well, you're letting out more positive ions, so it's going to prevent the membrane potential from getting too positive.
Good. Okay. So we have this rapid increase in charge inside, and by quickly letting out potassium, it decreases the rapid rise in charge. Positive out means less positive in, less increase in potential. It stabilizes the potential. Good. So we are at this new stable potential where something special happens, which is what?
Contraction?
Contraction. How does contraction occur? Is it just as soon as you're at a positive potential it happens?
Calcium is released by the sarcoplasmic reticulum.
Okay, that would initiate contraction, but there's a step before it comes out of the sarcoplasmic reticulum. That is true.
Balance.
Ion flow is balanced, and what ions are balanced?
Sodium and potassium ions.
Close. Potassium is right.
Potassium has to go out so calcium can.
Yes. That was the missing piece of the puzzle. Calcium comes in at this higher potential. Potassium moves out. Those are balanced to keep it at a plateau. Calcium activates release from the SR. Both of those activate contraction. Good stuff. Now, a lot of you are writing something. Did I say potassium the first time? Yeah, maybe?
Yeah, no, you did. Yeah.
I said
You said
I said potassium, good. Did I say not calcium? Did I say something else the first time? No? Okay, good.
It's just in a different order.
Just in a different order.
Just didn't-
Fantastic. That's why we're reviewing. So we have sustained contraction. Calcium is coming in to help stimulate release from the SR. Both of those activate contraction. When contraction stops, how do we return to normal? Phase 3 is repolarization. What are some of the things that help us return to a normal negative membrane potential? Yeah.
Sodium calcium exchanger helps to increase the level of calcium.
Sodium calcium exchanger.
Calcium channels have to close.
Calcium channels have to close, so less positive calcium coming in. Good, absolutely. Yeah.
The potassium channels have to open.
Potassium channels open, so positive ions in, move out. Good. Bringing that potential lower. If we piggyback on that idea, we don't want potassium out. We want it in. How do we get it back in?
Sodium, potassium, ATPase.
Sodium, potassium, ATPase, which also helps to restore the charge gradient.
Sodium out.
3 sodium out, 2 potassium in, so we're recycling potassium. We just let it out to bring the potential down. We're bringing it back in while also bringing the potential down. What else would need to happen? Calcium channels close. Sodium channels are closed. One other thing that might help too is we're pumping calcium back into the sarcoplasmic reticulum. We're not just using the sodium-calcium exchanger, but it's also being sequestered by Circa, the pump that stores it in the SR. Excellent. So I've not asked that question on a midterm yet, but you guys seem to have a good grasp on this topic, so who knows? It might be the first time for everything. So we have a pretty comprehensive view of ion movement, changes in potential, how that signal might be propagated. If it's sensed upstream and then is relayed downstream, we create a chain of action potentials. What I want to show you briefly here in this trace is how the pacemaker cells differ from typical cardiac muscle cells. So this is the sinoatrial node for comparison, and the purple line is analogous to the red line on the last slide. It is the trace of membrane potential through the cycle of polarization and depolarization. So normally at rest we are polarized. There is a negative charge in, positive charge out. Membrane potential is negative. You'll notice here, one, membrane potential is a lot less negative, only at minus 60. So there isn't as far to go until we reach that threshold for depolarization, that threshold indicated by the dashed line. Two, much more potassium leak. The slope of the phase 4 resting membrane potential is a lot steeper. So we naturally increase membrane potential. We don't need to sense from an upstream effector. And that's good because there is nothing upstream from the sinoatrial node. This dictates the sequence of depolarization in the heart. I hesitate to point out that once we reach threshold, the positive membrane potential is not due to an influx of sodium. It is due to merging an influx of calcium. That's one difference, and I'm not going to explore why that's a difference. I just want you to acknowledge that it's a difference. Notice third, or I guess that's fourth now, no plateau. So higher membrane potential at rest, faster leak and a steeper resting curve. Calcium is the major thing responsible for depolarization, and there's no plateau. There's no plateau because there's no real contraction in these cells. They are simply responsible for making the signal to propagate to other cardiac muscle cells. And then how the channels change with the permeability, we don't really care later. Let's just focus on those four. But obviously different. If you just looked at the traces of the lines, you could probably describe at least 3 of 4 of those pretty easily if there were no words on this figure. So that went a lot faster than I thought it would. we can, let's see, hold on. We probably can't get through the rest in half an hour, but we can do a large majority and have a truncated class Thursday or start the next section on Thursday, or we can just take a break now. We did go through a lot. There's a lot of information, so I'm content with letting you marinate on that information and take a little break, or we can keep going.
I'm good to keep going.
The least popular person in class right now. No, I'm just kidding. All right, let's take a quick look. Let's introduce the idea of the observation of that electrical stimulus. So what we just described was within one cell. There's no direction to the depolarization of one cell. But as soon as you sequence many cells together in time and in space, we get direction, and we can observe that direction from outside of the cell, and not just outside of the cell, outside of the heart, and outside of the body. External observation of myocardial depolarization. You've probably seen something very similar to this in A&P. Again, another arbitrary, stylized view of the cell. Here it's a square. Inside the cell is inside that square. Outside is anywhere else on the slide. And I'm just highlighting the upper surface as the plasma membrane, but the gray area is also plasma membrane. And I'm going to indicate the charge with positive and negative symbols as shown here. So we've already established there's a positive charge outside, negative charge inside. And what we want to observe is how the depolarization occurs within one cell. And you can use this as a template for a series of cells in sequence as well. Let's just think about this as one cell for now. If this one cell represents the entire heart, they're going to be lined up somewhat similarly like this. The net vector of electrical activity in the heart goes from the top, the base of the heart, to the apex, the point at the bottom. And this is a bit convoluted. It's backwards from what we know about the lung. The base of the lung is at the bottom, apex is at the top. Here the apex of the heart is the point in the ventricles. But roughly, these are parallel. This cell, this long, skinny cell, is lined up in line with the electrical vector of the heart. And if we were to measure or monitor electrical activity, we would simply place electrodes at either end of that vector. I'm only doing this because I want to catch most of the activity. Wherever I set up the electrodes dictates the vector of observation. And that's going to be important as we transition to understanding the 12-lead ECG. But here, I'm letting the main vector dictate where the electrodes go. So the electrode on the right-hand side, the positive electrode, goes near the point of the heart. The negative electrode goes near the root of the heart by the vena cava and the aorta. And we observe in kind. This is what would be set up for a lead 2 ECG. So you've done lead 2 ECGs, you've done the propagation of signals before. We're recapping and putting it in this orientation. So apex of the heart at the bottom on the right, base of the heart at the top on the left. Confusing, but those won't change, which is good. Now normally during a lead 2 ECG, depolarization first occurs in P wave, and then the major depolarization occurs in the R wave, the R aspect of the QRS complex. And those represent the depolarization of the atria and the ventricles, respectively. Now, I'm not trying to break up this long, skinny cell into atria and ventricles. It's just the vector as it changes during depolarization. So we have the normal situation playing out over here on the right-hand side. Positive charge outside, negative charge inside. And then as the cells proximal or upstream are depolarized, we see this wave of propagation where all of a sudden the charge inside is more positive. And we went through in detail how that occurs earlier in the class. Relatively more positive inside, relatively less positive outside. This is depolarized. The charge is not so different inside versus outside. And you saw the animation move from left to right, indicating that the sequence of events occurs in time. That signal is passed on to downstream cells as we progress towards the right side of the heart. So here, depolarization is moving from left to right as a positive wave. As a positive wave. It's a positive wave because we're measuring or monitoring the internal charge of the cell. That's the differential. That's what is polarized. That becomes more positive. That is a positive wave. Positive wave moving towards a positive electrode gives an upwards deflection. So I have my two nodes that help read the signal as it moves through space or moves between them. Depolarization is the act of making the cell more positive. As many subsequent cells become more positive, that is a positive wave of depolarization. As it moves towards the positive electrode, we get an upwards deflection. This is characteristic of depolarization of any cardiac cell, or the atria and the ventricles as we think about them at the organ level. And that makes sense. The P wave is always a small upwards deflection if you think back to a lead II ECG. And the R wave of the QRS complex, a massive positive spike, because there's a lot of activity moving quickly towards the positive electrode. Positive wave towards positive electrode gives a positive deflection. Not all aspects of the heart lie along that vector. The heart's not two-dimensional. It's not along one line. Aspects of the heart project radially to the sides. They project retroactively, backwards, not in line with the vector that we just established. They still depolarize, though. They still have a negative charge at rest. That becomes positive as they depolarize. But since our monitoring electrodes are fixed, the wave travels differently, or the relationship of the wave to the monitoring electrodes is different, and so the signal is different. If we ever have part of the heart where the signal is transduced from towards the apex back towards the base, from the bottom of the heart back towards the top, or from the right of the screen back towards the left. I'm just saying the same thing. Then the depolarization moves from right to left. Cells still depolarize. The signal is still sent through gap junctions and to subsequent cells. That signal is simply propagated in the opposite direction from what we just saw in the last slide. Still a positive wave, but here it's moving towards the left, and it's moving towards a negative electrode. Positive wave towards a negative electrode gives a negative deflection. It's just like adding and subtracting negative numbers. Taking away a negative is a positive. Adding a negative is a negative. Positive wave towards a negative electrode gives a downwards deflection. In both cases, depolarization occurs. Depolarization is a positive wave. What is repolarization?
Isn't it hidden?
Some of it is hidden, and you're jumping ahead. That's good. We are going to get there, but let's just think about the characteristic of the wave itself. Depolarization is a positive wave, so repolarization is?
Negative.
Why is it negative? Not just because it's opposite. Explain why it's negative.
Because the change in the ions.
Change in the ions. How are the ions changed?
You're removing positive charge.
Removing positive charge. Okay, so what is the culmination of removing positive charge?
The restoration of negative charge.
Restoration of negative charge inside the cell. Fantastic. Fantastic. Good. So the inside of the cell becomes negative, and that signal is what's transmitted upstream. Repolarization is a negative wave. If we have depolarized tissue or cells, as we repolarize, the inside of the cell becomes negative. Again, we return to our resting membrane potential. This often occurs in reverse. It's a negative wave towards a negative electrode. If we subtract a negative, we add a positive. It's an upwards deflection. Some repolarization is hidden. That's what Dessa pointed out. It's absolutely true. This is a small part of what we can observe through a basic 2-lead ECG, or a lead 2 ECG. Being that it's a small part, we need generally silence from the rest of the heart, and that happens sometimes but not always. Repolarization of the atria is what she was thinking of, that is lost while the ventricles are depolarizing. That is a disruptive, large signal that we can observe where any other small electrical activity is overshadowed and lost in the noise. But we can observe the T wave. T wave is the repolarization of the ventricles. Nothing else is going on at that time. And the T wave in any lead 2 ECG is always an upwards little bump. Not always an upwards bump. We'll see in the 12-lead discussion where that might not occur. In a healthy individual with electrodes placed properly, it's an upwards deflection. It's a negative wave towards a negative electrode. Gives a positive deflection. And so if I take this setup and apply it to a person, in the classic configuration, judging by the orientation that we assume the heart to be in a normal anatomical position, the positive and negative electrodes are placed as such. Positive towards the apex at the base of the heart. Towards the apex at the bottom of the heart. Negative towards the base at the top of the heart. It's confusing. I get it. All of the information that we saw in those last two slides can simply be rotated and applied here. The vector is generally from upper right to bottom left. Repolarization is in the opposite direction. Here I'm showing you another electrode, this left arm electrode. on the left side of the figure, but to your right as you look at the slide, which serves as a ground electrode to account for any background noise or background activity. To correct the signal we observe between the two positive and negative electrodes so that any extra noise is removed. It's outside of the vector. It shouldn't pick up any electrical activity. It's usually placed over bone, which is not electrically active. And so any residual activity of the signals on the wires or friction of a person on the chair or movement of their feet or any residual activity in the tissues of their body is accounted for by that ground wire. And then if we superimpose this over the heart, same electrodes, same positioning, same vector, positive at the bottom right on the screen, negative towards the top left, we get a rough representation of where we collect that information during the cardiac cycle. We're only ever monitoring along this thick black line, but the information that we can pull out of just this one axis is pretty impressive, and that's shown over there on the right-hand side. So the readings from just this one lead, this pair of electrodes, is shown on the right-hand side. We have the P wave, which is depolarization of the atria. We can understand how and why that would occur. It's proximal, it's an early part of the cardiac cycle. There's a bit of a gap between the pumping or the contraction of the atria and the ventricles, just to make sure there's enough filling time. The ventricle contraction is the QRS complex. We think about it together because often it's hard to separate, but here you have an attempt to separate the different components of the QRS complex. Practically, they're inseparable. They do happen in sequence, but it's almost instantaneous because the conduction is so fast and so forceful. And then we observe the T wave, the repolarization of the ventricles, after all the major electrical activity has subsided and we're back to a stable baseline. We can hear that small repolarization or observe that small repolarization, which we can't do for the atria, lost in the middle of the QRX complex. And I don't even know what wave you would call it. You'll never observe it. No, that's not true either. We'll see situations where we do observe the repolarization of the atria in our 12 lead traces. This is really good because we'll have a lot of opportunity to go through examples of the 12 lead ECGs. And so maybe a more comprehensive representation of those on the midterm as well. Who knows? You guys are going to be mini clinicians by the time you're done. Okay, now I'm going to call it. We're still early, but let's leave it there. We've covered a ton of stuff, some complicated aspects. There aren't many slides left, and we'll get through those easily on Thursday. Set up the planes of the 12-lead ECG before we start to evaluate the information that we get from the 12-lead ECG, which is also Lab 2. That happens next week, so you'll be well prepared in advance for that. Any questions before we end for the day? Yeah, Leanne.
So, did you say the vector goes from the apex to the base or the other way?
The vector is along the axis between the apex and the base. We only establish a direction by placing the positive electrode at the apex. If we swap the electrodes, the direction would change too.
Okay, but when we do it, that's...
When we do it, we're generally observing in the direction towards the apex, towards the bottom of the heart, towards the bottom left, from the top to the bottom.
So we go, okay, so base to apex.
Base to apex, yeah. Base to apex, negative to positive, top to bottom.